webinar titled It's ADHD, Now What? Finding Clarity After the Diagnosis, presented by Dr. Larry Young of Young Psychiatry. Before we get started, I would like to introduce myself and share about upcoming opportunities for families to engage with Groves. Then I will review a few housekeeping items and introduce our presenter. My name is Linda Roslansky, and I'm the Director of Outreach at Groves Learning Organization. I have the great pleasure of working alongside our Learning Center and admissions teams. We have many events to engage with GLOW and explore our Academy and Learning Center. Our first open house of the school year will be on November 12th, where you can meet our new head of school, Jessie Coyle, hear from parents and students, and tour our beautiful, newly renovated school. We have current openings in some of our Learning Center services like diagnostics and tutoring, and have multiple GLOW Ed Series events coming up as well. Please check out our website for more information. To help us stay on schedule, your camera and microphone have been turned off. Our speaker will take questions at the end of the presentation. Please use the chat bubbles at the top to put in your questions, and our presenter will take those at the end. I will help moderate those to help stay on track. Now I'm very pleased to introduce our expert presenter. Prior to opening his private practice, Dr. Young practiced for over 13 years at Prairie Care in Abbott Northwestern Hospital, working with patients in psychiatric outpatient clinics, partial hospitalization programs, and on the child adolescent inpatient units. He also serves as the team psychiatrist for the Minnesota Vikings and consulting and treating psychiatrist for the Minnesota United, Wild, Lynx, Twins, and Timberwolves. And he supervises residents at the University of Minnesota in psychodynamic psychotherapy as the adjunct assistant professor. It is my pleasure to turn it over to Dr. Young.
Well, thank you, Linda. Thanks for that introduction. You can hear me okay? The sound is good there? Okay, very good. Well, thank you everyone for joining today. As Linda mentioned, I'm a psychiatrist in Minneapolis, and I work with children, adolescents, and adults in my private practice. What I'll do today is present this topic to you from that perspective, from the perspective of an outpatient clinic psychiatrist. I work predominantly in the community. As Linda mentioned, I work with some of the professional sports teams as well. But the large majority of my patients are children and adolescents coming to see me in my office here in my private practice. And what we'll talk about today, as Linda mentioned, is ADHD, and specifically what happens after you get the diagnosis. What does the diagnosis mean? What do you need to know in terms of how to move forward? And for the most part, this applies to children, adolescents, and adults. But for today's purposes, I'm focusing a lot on children and adolescents, and specifically what they go through on a day-by-day basis. So hopefully you can see the slides as I'm clicking through. I do apologize. Linda and I discovered there's some formatting errors when I moved my PowerPoint over to this format. So hopefully you can see okay. Please mention in the chat if you cannot see the slides or if they're garbled in any way here. But the objectives for our talk today, we want to look at various symptoms, clinical presentations, and even some neurobiological foundations of ADHD, what we're seeing in the research. We want to consider specific case examples and specifically how other mental health symptoms and diagnoses can co-occur with ADHD, sometimes mask ADHD or even be masked by ADHD. We want to understand some basic tools used to diagnose ADHD in the first place, and then start looking at the various treatments for ADHD and how they might be best used. Obviously, people usually have a lot of questions about pitfalls and adverse effects from certain treatments, especially medication treatments. So we'll get into that as well. And I have no financial conflicts to report for this talk. Okay, so first and foremost, what is ADHD? What compromises ADHD? There's basically two symptom domains. There's the inattentive symptoms, and then there's the hyperactive symptoms. Kids and adolescents need to meet 6 of the 9 criteria in either the inattentive or the hyperactive impulsive or both, and adults only need to meet 5 of the 9 criteria. And those inattentive symptoms of ADHD are probably pretty familiar to most people. This might be a kid, for example, fails to give close attention to things and makes careless mistakes, has difficulty keeping their attention focused on tasks or even play activities. And of note, that is very important that these symptoms do need to occur in 2 or more settings, not just at school or just at home, but in different settings like school, home, with their friends on the playground, etc. So the symptoms apply to different settings at all points throughout the day. This kid often doesn't seem to listen when spoken to directly. So parents will say a lot of times, yeah, I have to tell him something 30 times before he even seems to hear it. That's pretty common. They don't follow through on instructions. They fail to finish things like homework or chores. They have trouble organizing tasks and activities. This could mean they can't organize school assignments or projects well, but it could also mean that they don't organize their backpack or their locker very well either. Everything's always a mess. They often avoid things that require a lot of mental effort. So if there's a subject in school like reading or math that's particularly cumbersome to them, they might completely blow it off or put it off till the end. It's just really hard for them to get through those tasks that require a lot of mental effort. They lose things often that they need. This can be especially severe. I had one kid who lost basically like a new cell phone every week. Their parents obviously were at their wits' end, but that can be a common symptom. They get easily distracted by extraneous stimuli. So they're in class, they hear a friend talking, now they're focused on that conversation. They don't hear anything the teacher says for the next 10 minutes, or they see a bird fly outside the window and they're gone, and it's hard to get back to what was happening in the class. And they can often be forgetful in daily activities as well. The hyperactivity impulsivity symptoms, this is a kid who fidgets and squirms in their seat a lot. They leave their seat when they're supposed to stay seated, like at school. They run or climb when they shouldn't or in places they shouldn't. They're unable to play quietly, and this is especially in play activities. Their parents will say they always do everything so loud. They're just always so loud. They're often on the go as if driven by a motor. They don't seem to stop. They talk excessively sometimes or blurt out answers. This is especially obvious in the classroom. They blurt out answers a lot of times without raising their hand, or they even blurt things out to their friends that they regret later. They have difficulty waiting their turn for things or waiting in line, and they often interrupt or intrude on others. And again, like I said, you don't need to meet all these criteria to get an ADHD diagnosis. It's just you have to meet, if you're a child or adolescent, 6 of the 9 in one or both of these categories. And that's why now the terminology is a little different than it used to be. We don't refer to ADD anymore and take the H out like we used to. Now it's either ADHD predominantly inattentive presentation, meaning you're meeting mostly the inattentive symptom criteria, but not the hyperactive impulsive, or the opposite, which is ADHD predominantly hyperactive impulsive, or you can have ADHD combined, which is that you meet criteria for both types of symptoms there. There's some question as to how ADHD is best diagnosed. So I diagnose ADHD obviously from a clinical psychiatric evaluation. I have patients come in to see me for a 90-minute visit. We go through ADHD symptoms. Okay, how debilitating are these symptoms? What settings do they experience them in? What do the teachers say? What did you hear at the last conferences? What's going on at home? You know, et cetera. We go through a list of, okay, we'll go through other diagnoses. Is there any anxiety, any change in mood? Are there other behavioral issues? Is there an autism spectrum disorder they've been diagnosed with? And just try to put all that together in a clinical evaluation. A lot of parents come to see me, they've already had their child go through neuropsychological testing. So this is when you sit down with a psychologist, you go through a battery of different exams and exercises meant to see, okay, are you meeting the criteria through these methods? Does that child's brain sort of function like the brain of someone with ADHD? For example, maybe they have a really high intelligence level, but their working memory is a lot lower, meaning how many things they can kind of keep in their brain at once. Or maybe their IQ is up here, but now their processing speed is lower. How fluidly do they go from one task to another? So those can be some signs on psych testing that someone has ADHD. And again, it's not everything, but it is a pretty big piece of the puzzle. So usually, from a clinical perspective, I do go over those resources and ask people to consider the neuropsych testing if they haven't done it already. There's various rating scales that people fill out. Parents fill these out, teachers fill them out, the kids themselves can fill these out, where you look at specific ADHD symptoms, how debilitating they might be, that aids in the diagnosis. And there's some focus right now on QEEG, or quantitative electroencephalography. So this is an EEG like you might get from a neurologist if you have a seizure disorder, placing electrodes on the scalp, trying to see where the electricity goes in your brain. Obviously, this is the way they diagnose seizure disorders, epilepsy. But there's some hope that maybe we can really pinpoint, okay, how does this electricity move when a kid is given certain tasks, and is that a way of being able to diagnose ADHD? And a lot of people use the QEEG with really deft skill. It's just that I think a lot more research needs to be done to really figure out how accurate it might be with different kids and different presentations. So just a word about the neurobiology of ADHD, and in fact, this is quite common with just about any mental health diagnosis. Obviously, the organ that we study is the brain, and the brain is a big black box, and we don't know a lot about it, and we're learning more. But the general theory that I'll put forward in a lot of the discussion today is this: the theory and the belief that when brain cells communicate with each other, they basically send neurotransmitters from one neuron, one nerve cell, to another neuron across a liquid gap between the two. And they do this by means of neurotransmitters. And you've heard of a lot of these neurotransmitters before: dopamine, serotonin, norepinephrine. And what happens is, so on this animation, this diagram I have, on the left, you see what we call the presynaptic neuron, the neuron, the original neuron, and there's an electrical stimulus coming down the axon of that neuron, and that electrical stimulus encourages that neuron to take these little, we call them vesicles. They're like little water balloons full of neurotransmitters. And in this diagram, it's depicted by those purple sort of balloons there with the little yellow neurotransmitter molecules in them. And the electrical impulse encourages that vesicle to fuse with the outside membrane of the neuron and basically open up and release its contents into that liquid space, the synapse between the two neurons. And those neurotransmitters, like dopamine and norepinephrine, they're floating out in that surface. And the postsynaptic neuron, the second neuron, the one that is being communicated with, has receptors on the outside that sense the neurotransmitter. Once the neurotransmitter hits that receptor, now the electrical stimulus now propagates down that second neuron, and now two neurons have communicated with each other. Now, the theory is, in ADHD, as well as in other illnesses like depression and anxiety, those neurons are not communicating well, and it's hard to say, is there not enough neurotransmitter? Are the receptors faulty? One theory is that there's a vacuum on the presynaptic neuron, the first one, that sucks up the neurotransmitters to repackage those vesicles, those water balloons, with neurotransmitter, and maybe it's working a little too well. And so some of these drugs block that vacuum to keep the neurotransmitters out in the space a little longer and make sure that the neurons communicate with each other. So the two neurotransmitters we'll talk a lot about in terms of ADHD are dopamine and norepinephrine. And this diagram came off of an American Academy of Child and Adolescent Psychiatry Facts for Families. You can look at the ACAP website. It's fantastic. I would direct anybody there to get more information on ADHD treatment, et cetera. It's a very reputable site. And then I also want to briefly talk about brain regions implicated in ADHD. So sorry, the diagram, the illustration might be a little fuzzy for you, But basically, as you see on the left side of that top brain diagram, the dorsolateral prefrontal cortex is really one of the main regions that's been studied. The prefrontal cortex is the part of the brain that houses executive functioning. So the ability to plan and stay focused and organize yourself, that's all right there in the prefrontal cortex. Now, for better or for worse, that is one part of the brain that is really slow to come online and to really connect with other parts of the brain and really achieve its full functionality. That's why we all remember that as kids and adolescents, we make very impulsive decisions. We don't really think things through as well as we do when we're adults. And then usually they say we sort of get our adult brain, which essentially means that prefrontal cortex is now coming online around age 24, 25, 26, 27, somewhere in there. And that prefrontal cortex is working a little bit better. But it's it's not really functioning especially well with children and adolescents. Also on that lower brain image, the interior of the brain, we see the anterior cingulate cortex in blue. That's another region that's been heavily studied. We've seen in studies that for kids and adults who have ADHD, the volume of those two pieces of the cortex can be a little smaller. Those brain regions can be smaller. We also know that stimulant medications can increase activation in those two regions of the brain too. So a little bit about the neurological correlate here of ADHD. And again, I keep saying things like we think and we believe and we've seen, because obviously you can't take a biopsy of a living person's brain. It's impossible to know with certain functions where are the neurotransmitters exactly going and what's happening. And so these are based on animal studies and other microbiological data, but we're piecing it together kind of slowly but surely here. A quick word about the prevalence of ADHD. How common is it? It's an estimated 7 million or 11% of US children ages 3 to 17 in 2022 when this study was done that have ever been diagnosed with ADHD at some point in their lives. So that's a pretty heavy number. Other numbers say, okay, at any one given time, maybe 5 to 7% of kids are currently working on ADHD, but that's a pretty big number. It's a pretty common issue. In addition to that, we know that boys are almost twice as likely as girls to be diagnosed with ADHD. We're not sure exactly why that is, but as you can imagine, I think a lot of hyperactive, impulsive boys who are swinging from the light fixtures at school, like a lot of us did when we were younger, you're a little more likely to get clinical attention because you're more disruptive and kind of getting in trouble a little bit more. So that can be part of the picture there too. And some additional focus has to be placed on, how do girls present and how do we get them into treatment faster? Just as a side note, it looks like an average of 50%, about half of kids with ADHD go on to meet ADHD criteria as adults. So in other words, 50% of kids who have this diagnosis, the symptoms resolve over time and they no longer meet criteria as adults, but some adults still do. And we think that of the adults with an ADHD diagnosis, 50% of them get a diagnosis that just comes, they struggle with as adults. They didn't struggle with it as children. So there's a pretty big comorbidity or co-occurrence of different disorders with ADHD. So for example, a kid, adults too, are more likely to be diagnosed with an anxiety disorder along with ADHD. So things like social anxiety disorder, where they have constant worries about how other people see them, and they have a lot of anxiety in social situations as a result. Excuse me. Generalized anxiety disorder, which is when a kid has a lot of worries about a lot of things a lot of the time. It's hard to control the worries. And then panic disorder, where a kid can actually have physiological symptoms like racing heart, shortness of breath, shaking, sweating, etc., when they get very anxious. Of note, they have a lower overall risk for anxiety and depressive disorders when a kid engages in ADHD treatment. You're lowering your risk of an anxiety diagnosis with the treatment. Depression and bipolar disorder, mood disorders can co-occur with ADHD. Oppositional defiant disorder. Now, a quick note on this. A lot of times I feel, and I see this all the time in my practice, kids are given an oppositional defiant disorder when it's really ADHD that's in the driver's seat. So for example, if I have ADHD that's not in good control and my parents ask me to take out the garbage, I'm being impulsive because of the ADHD. And my first thing I say, I'm just going to blurt out the first thing on my mind, which is, no, I'm not going to take out the garbage. Excuse me. Well, now I've been diagnosed with being oppositional when in fact it's the ADHD that's at the helm there. And for a lot of kids, when you treat the ADHD, these oppositional symptoms go away. Or they're in better control. Also substance use disorders, and a quick note on this. Excuse me. There is a lot of comorbidity with substance use disorders and ADHD, but there's a lot of focus these days on how there is a risk for abusing ADHD medication. And that may be true, but there is a lower risk for substance use disorders when somebody is engaged in ADHD treatment in the studies that we've seen. And if you think about it, that makes sense. Part of substance use is coming from impulsivity. If you treat that impulsivity, you probably have a lower risk for substance abuse. Now, it doesn't mean that meds like stimulants are good for everybody. And for someone with certain kinds of substance use disorder symptoms, it might not be right for them. But I have seen this quite a bit. Substance use can actually decrease when ADHD is treated. And I didn't put this on my slide, but also autism spectrum disorders. In the past, in the previous diagnostic and statistical manual, those two diagnoses, ADHD and autism spectrum, were exclusive. You couldn't have the two disorders together, but now you can, and it's quite often to have both of those diagnosed together as well. So there's one concept I think we really need to dive into, again, before we investigate the treatment, which I know we want to dig into as well, but it's important to consider what you're treating. Now, one of the problems here is that ADHD is often readily diagnosed, especially in the Twin Cities area. You know, we have a lot of good resources for people to get, find that diagnosis and get that diagnosis. And the ADHD medications themselves are very effective. And because there's not a lot of me in the community, a lot of child adolescent psychiatrists, a lot of times the burden falls on pediatricians to prescribe these meds. Nurse practitioners are kind of coming in and filling in some of the void that's left by lack of psychiatrists in this area, well, across the country for that matter. And so what happens is, we kind of go for the low-hanging fruit and say, okay, there's definitely ADHD here, let's just treat that. Well, there might be some problems with that too that you really have to consider, and a lot of it comes down to those co-occurring diagnoses I mentioned. So here's one example that happens quite frequently. I see this in my practice all the time, and a lot of kids will come in with an anxiety disorder as well as ADHD. Now here's an example that involves generalized anxiety disorder. So like I mentioned before, GAD is the presence of excessive worry about a lot of topics for a long period of time. It's hard to manage the worry. They often lose sleep to these worries, and they usually have a few of the following symptoms. They can be edgy or restless. They can tire easily and get more fatigued. They have impaired concentration, feeling as if their mind goes blank. They can be more irritable. They can have increased muscle aches and some difficulty sleeping. So just by looking at those symptom criteria, you already see a lot of overlap with ADHD. Looking at edginess and restlessness, for example, a lot of kids with ADHD experience that. And of course, impaired concentration or feeling as though your mind goes blank. That can be very typical and misinterpreted a lot of times as ADHD. Now, a lot of times I see a kid come in with all these symptoms, the ADHD, the generalized anxiety disorder, and you have to make a decision. What do you treat first? Is there one of these things that's kind of, again, to use the phrase, in the driver's seat, kind of controlling things? Is it all a big soupy mess and it's hard to kind of split it up? But a lot of times I'll sit and I'll talk with kids and I'll try to really listen to what's going on, and I'll try to get them to kind of paint me a picture of what happens in a given school day. And sometimes we find out, you know what, it's not actually the ADHD that we need to worry about, it's the anxiety here. Because they'll say things like, well, I can pay attention to what the teacher's saying, but what happens is I'm really anxious about a lot of things. I'm overwhelmed. My mind is racing with all of these worries, and that's why I can't focus. Or they'll say, like, I'm avoiding the work because doing the work makes me anxious. I don't even want to think about it. And so for that kid, you might be better off treating the anxiety before you treat the ADHD. Then you're also a lot less likely to get, any kind of anxiety type side effects from ADHD medication too. So again, you have to consider what are you treating and what do you treat first. Another example, this is a lot of kids I'll see who have obsessive compulsive disorder, OCD, and ADHD. And as you probably know, OCD comes with either obsessions or compulsions or both. An obsession is like a recurrent or persistent thought or an urge. It's hard to control. It's very disturbing. This can be things like, I'm very worried about germs. I think germs are going to kill me. Or I'm really focused on things being equal and symmetrical all the time. Or I have these, urges or worries like I might hurt somebody, even though I know I don't want to hurt somebody. I can't get it out of my head. What if? And then the compulsions come in. I'm so worried about germs that I have to run to the bathroom and wash my hands in scalding hot water 10 times every time I touch a surface. Or I have to open and close the door to my bedroom 36 times to get it just right. They use this phrase, just right, before I can go to sleep at night. So obviously a very debilitating problem. And sometimes I'll sit down and I'll listen to a kid kind of tell their story when they have ADHD and OCD. And again, we find out, wait a sec, it's not really the ADHD, it's the OCD that's to blame here. So they're taking 6 hours to read 10 pages of a novel, but it's not because they're forgetting each paragraph and they have to go back and read it because they weren't paying attention. It's that they read the paragraph and they felt they weren't getting it just right and they had to do it again. And that's why it's taking them so long, and that's why they're falling behind. Or they have to redo a homework assignment 30 times before they get it just right and they feel comfortable handing it in. So again, another example where, okay, let's look at another disorder and some other issues that could be going on. We might have to treat those first before we get into the ADHD. And here's just a simple Venn diagram to kind of display this, where if you have a kid who might be struggling with generalized anxiety, they're having, difficulties in school because they're overwhelmed, they're avoidant. A kid with ADHD can't focus and organize themselves, and that's why they fall behind. And a kid with more oppositional traits, or there's this profile of autism spectrum disorders now called PDA, or pathological demand avoidance. I don't have time to get into that today, but kids with oppositional defiant disorder, or a PDA version of an ASD, they often just kind of have a fight, flight, or freeze response when asked to do anything. And so they can be very avoidant. They don't want to approach the schoolwork for various reasons. And so obviously it's very important to listen to this child, to kind of peel apart the onion here and figure out what's at play. And you want to also figure out, is one problem downstream of another, right? It's because they're not focusing in school, maybe the ADHD starts the ball rolling, and that's why they're getting anxious later, or that's why they're struggling with depression symptoms. And so you really have to figure out, okay, is something downstream of another issue? But let's say you've gone through all of that and you've decided, okay, the ADHD is in the driver's seat. We really need to treat this first. This is the big thing we need to look at. I often encourage people to consider psychosocial and educational interventions first. So there's a lot of therapy that you can do for ADHD, specifically a version of cognitive behavioral therapy. There are tutors that help, sitting down and helping a kid to focus on the work and teaching them some different study skills. That can be helpful. Parent training. There are courses and therapists that do parent training for kids, or for adults, or for parents, especially of very young kids with ADHD. This can be very helpful. Classroom accommodations. So a 504 plan, which gets its name from Section 504 of the Rehabilitation Act, is a series of classroom accommodations a kid can get at their school to help level the playing field between them and kids who don't have ADHD. So this can be accommodations like extended test taking time or being allowed to take tests in a room with just a proctor without other students there. And these accommodations are a little easier to get these days than they used to be. Something that's a little more stringent is an IEP, an individualized education plan. This comes from the Individuals with Disabilities Education Act. And this is a little more stringent and it involves usually special education funding. Schools usually will ask a kid to go through some pretty specific testing before they can grant an IEP. And usually it involves specified instruction, pull-out services, that kind of thing for the kid. It's a little more stringent in schools. They do have to guard it a little more closely. It's a little harder to get an IEP these days. And for private schools, they're not beholden by law to do 504s and IEPs, but they have their own versions, individualized service or learning or accommodation plans. I also want to put on here, a couple things I left off the slide. Occupational therapy can be very helpful. This is a little bit more of a physical therapy. It works especially well for young kids, and it really gets them to understand their bodies, where they are physically in space, and it really helps them to control ADHD symptoms. There are some online programs, some apps that have some promise for helping kids to control ADHD. There is some initial research on trigeminal nerve stimulation. We're still trying to figure out if that can be helpful for ADHD. And of course, I didn't put this on the list, but good old-fashioned exercise. We have more and more research now that shows that kids getting out and exercising can actually help their focus, reduce their ADHD symptoms, just like our grandparents told us generations ago. I think that another psychosocial intervention, which I think deserves special focus, is ADHD coaching or executive function coaching. This is a little bit like therapy and tutoring kind of blended. That's not a great summary, but it's you're meeting with an ADHD coach to learn certain skills, to understand yourself and your ADHD a little bit better. Younger kids, elementary, middle school age kids, this might focus on parent coaching, building awareness in that kid of how their brain works, how their body works, self-discovery around different challenges they face, strategies to gain support at home and at school, even with their friends. But for older kids, ADHD coaching looks more like supplementing their academic experience. So they might bring their schoolwork into an ADHD coach, go over it together. They do learn specific strategies to try to keep their focus a little bit longer, but they might even go through the work with that ADHD coach, using it almost as an avenue for discussion about their ADHD and learning a little bit more about their issues. In general, ADHD coaching can look at planning and management skills, can build healthier self-esteem and relationships, bring about clearer judgment in certain situations, increase self-motivation and time management skills, and hopefully lead to a greater sense of self-efficacy. Now, I did include some of these resources in for people. When you get the slideshow, you can check out some of these resources. So Attitude Magazine, ADD-Etude Magazine, very helpful resource on ADHD coaching and pretty much all things ADHD. The ADHD Coaches Organization, they have a good website going through what makes a good ADHD coach. And CHADD, CHADD.org, again, not just for information on this, but for information on all things ADHD. And a lot of this information I also picked up in my discussions with Catherine Levis, who's at Groves, and she said certainly reach out to her by that email address if you have specific questions for her, especially on executive functioning coaching. So now let's say you've tried a lot of these interventions and maybe some things aren't working, maybe your child has a little bit more severe symptoms, and you're wanting to look at medications here. There are some basic principles to consider when you go and get to the step of treating ADHD with medication. One thing, and I hinted at this previously, ADHD medications are incredibly effective. In studies, they've been shown to be effective 70 to 80% of the time. That is through the roof in terms of psychiatric psychotropic medications. If we have an antidepressant or an anti-anxiety medication that barely beats placebo, and it's effective for 35 to 40% of kids who take it, that's a small miracle. These meds are effective 70 to 80% of the time. So we have a lot of research that they're very effective. But you have to consider, what kind of symptoms are you treating? The inattentive, the hyperactive impulsive, both. Different medications might be more effective for one group or the other. Are you treating multiple issues with one medication? There's the norepinephrine reuptake inhibitors like Strattera and Qelbree. They can be very effective for ADHD, but as their name suggests, they also can function a little bit like a mood or an anxiety medication, and they can help those issues too. What age group are you treating? For example, you're not going to see this in the literature, but in my practice, a lot of times I see that the younger kids might do better with a short-acting medication, but the older kids, the adolescents, college age adults, they do better with a long-acting medication. You want to consider that patient's schedule. Are there times of day that are easier than others, times of day that are more difficult in terms of your classes throughout the day? How long does each medication dose last? If you're taking a short acting, can you get to the nurse's office after lunch to take a second dose, that kind of thing. And a lot of times I'll have kids, elementary school kids, look, in the morning I have, to do reading and math, and it's all very, it's hard to focus on. But then I have lunch, recess, art class, gym class, and it's like all these things are fun. I'm focused, and I get to move around a lot. Maybe I only need a short acting in the morning, so that's something to consider. You want to consider sports and after school activities. Not only is an ADHD really needed for that, but an ADHD med needed for that, but also does that kind of disrupt our treatment? Maybe you need a short acting booster when you get home from practice to help you with your homework if you're in high school. Weight and appetite and sleep issues. I mean, these are some of the biggest side effects of stimulants. If someone is kind of underweight, you really want to be careful with stimulants. They might lose appetite and lose more weight. Or if somebody's having trouble sleeping, you really have to monitor those long-acting stimulants especially. They might have more trouble with sleep. What have you tried before, and what were the positive results versus the adverse effects? That's really important history. You want to consider the delivery method. Can this kid swallow pills? Well, there are liquid formulations and patches if not. There are short-acting meds that come in tablet form. You can cut those in half and use very, very minute dosages. And then monitoring the supply and the storage. So a lot of kids, again, forgetfulness is a primary symptom of ADHD. They're going to forget to take their meds in the morning. Parents really have to put the med out for them or even watch them take it every morning. There are college dorm issues. Sadly, there's a little bit of a black market for these meds in colleges. I tell college kids all the time, hide your supply, put it even in a little lockbox or something, because you're going to have people coming in and out of your dorm room. Next thing you know, the meds are gone and you have no meds for another 30 days. And also the substance use disorder history. Again, not to say that this stops me or anybody from treating ADHD, but if someone has a specific history of abusing stimulant medications, you're going to want to be extra careful or look at other treatments for that kid. There is a trial and error here process that people go through, even with pharmacogenomic testing. A lot of talk these days about GeneSight and other pharmacogenomic tests. They can be very helpful in terms of seeing how your body metabolizes different meds, but they've decided that they haven't necessarily found the most reliable genetic markers for the ADHD medications. So these tests aren't as necessarily reliable for all the ADHD medications versus if you're looking at an antidepressant or an anti-anxiety medication, et cetera. You also want to look at family history. Is there anybody in the family who's done especially well with a certain med or especially poorly with a certain med? Also, you want to start low and go slow on the dosing, a little less likely to get side effects that way. And you want to consider the time to effectiveness. A stimulant, if it's at a therapeutic dose, you're going to be able to feel the differences with that the first or second or third day that you take it. It should be pretty obvious they're in and out of your system very quickly. Versus a non-stimulant, it might take weeks and weeks for that medication to sort of quote unquote build up in your system, for the effect to build up enough for you to feel it. So that might take some extra time. So those are just some preliminary, some generalities, I guess you could say, about some of these meds. But I want to get into the specific meds before we finish up here and just look at how they differ. So the first family of medications, and a lot of people know about stimulant medications. These are meds that are quite commonly used, and a lot of pediatricians feel comfortable prescribing them. They're quite often prescribed. Unfortunately, as people have probably found out, there's also a shortage of them in this country that came around with COVID, and we still haven't corrected that shortage yet. So sometimes they can be hard to find. But basically, within the stimulant medication group, there are two families: the methylphenidate family and the amphetamine family. And then within each of those families, you have short, medium, and long-acting meds. So the short-acting meds in the methylphenidate, these last, each dose is about 3 to 5 hours of an effect. You have meds like, and I'm using the brand names here because the label will say methylphenidate for all of them, but there are different brand names that you can order that have different types of formulations, different effects. So Ritalin is a common, 3 to 4 hour medication, comes in tablet form. Methylin is the chewable version of this or the liquid version of this. Focalin is a kind of a different version of the methylphenidate molecule. That's called dexmethylphenidate. And over in the amphetamine family, the short-acting meds, you may have heard of Adderall, Avikio, Zenzidi, which I don't know if I'm pronouncing that right, but every time I say it, I kind of laugh because I'm Italian and it sounds like a pasta dish. I don't know, man, I don't know. Sorry to the makers of Zenzidi there. Maybe I'm not saying it right. But anyway, another short-acting amphetamine that can be helpful. And just to note, the side effect profile with all of these stimulant medications is pretty similar. There might be small differences between meds, but basically you have to watch for predominantly the sleep and appetite issues, right? That kids lose a little bit of sleep sometimes, or maybe they're not as hungry. Now, it doesn't mean they can't eat. And I see this with my Vikings players all the time. I treat them with stimulants. They say, yeah, my appetite's a little lower, but I've seen them eat in the cafeteria at the TCO practice facility, and they can put down, 3 helpings of steak and potatoes just for lunch. So they're doing fine. They can still push themselves to eat. Kids will say this too. They're just not thinking about food as much. There can be possible increases in heart rate or blood pressure. We have to watch for that. Excessive sweating for some kids, anxiety or jitteriness, mood swings or irritability. And to point out, there can be a rebound effect where when the meds wear off at the end of the day, that irritability can be pretty severe at the end of the day. Headaches, stomach aches, and we have to watch that they're growing and they're achieving height gain over time adequately too. Now, within the intermediate acting family, again, 6 to 9-ish hours, 4 to 9-ish hours, I guess you could say, with both of these families. Metadate CD and Ritalin LA are two of the bigger ones in the methylphenidate family. There is a liquid Quillavant and a chewable Quilichew that people can use. And then the dextroamphetamine meds over in the amphetamine family there are intermediate. And then the extended release. I find that these generally work better for the high school kids and adults than they do for the younger kids. These can really pack a punch. I mean, anywhere from 10 up to 16 hours of an effect. So for a lot of kids, it's like they take these meds and they can really get that affect flattening. Parents will say, whoa, they just really look like a zombie on these long-acting meds. It's a little less likely in an adolescent. It can still happen though. But in any case, very long-acting. You take 1 dose in the morning. It should get you through the whole day. In the methylphenidate family, we have Concerta, Adhancia, Focalin XR, Contempla XR, which is orally dissolving, the Daytrana patch, and again, the Quillavant and Quilichew at higher doses can be longer acting. Now, the Jornay PM, the Jornay, I want to point this out. This is an interesting formulation. It doesn't start working until it hits your colon. So when you swallow it, you actually take it at night, the night before, and it kind of goes through your GI tract overnight, and it's not till it hits your lower GI tract that it starts working. This can be especially helpful for kids who get out of bed. These are the parents come in complaining of the whirling dervish, the Tasmanian devil. He gets out of bed and he's already swinging from the chandeliers at 7 in the morning. Sometimes meds like this can be helpful. You take them the night before. They help a kid kind of transition out of the house to get to school calmly in the morning, get through their routines. And Azteris is an interesting newer formulation. It's got a prodrug in it of the dexmethylphenidate along with dexmethylphenidate for a longer acting effect. And then in the amphetamine family, a lot of people have heard of Adderall XR and Vyvanse. Vyvanse has a chewable, Mydayis, Dynavel, Adzenys. These are all sort of longer acting amphetamine medications. And to point out, some kids will just do better in one family than the other. So a lot of times if I say, okay, a kid comes in, they've already tried Concerta and Focalin XR and they haven't had great results, I say, yeah, let's flip to the other family and try Adderall XR. Sometimes that can be all that you need to do. Okay. Now, a quick note again about what we think is the mechanism of action of the stimulant medications. Different medications can either increase the output of dopamine, or it can block those little vacuums and decrease the reuptake of the dopamine out of that synapse, and maybe to some extent norepinephrine as well. So this is just a kind of a complicated diagram sort of showing that you're doing kind of like I said in the previous slide, providing for more of these neurotransmitters to be in that synaptic liquid space between the two neurons and to allow those neurons to communicate more accurately with each other. So now the non-stimulant medications, and let's start with the norepinephrine reuptake inhibitors. These are the medications that I mentioned previously that kind of, as the name suggests, they sound a little bit like selective serotonin reuptake inhibitors or selective norepinephrine reuptake inhibitors. Those are different versions of antidepressant anti-anxiety meds. So these are the meds that might have kind of like a hybrid effect for somebody treating ADHD, but maybe a little effect on mood and anxiety as well. These are meds like Strattera and Qelbree, where, as the diagram shows you, they're mostly working on keeping more norepinephrine in the system to help the neurons communicate with each other. Now, these meds are kind of in your system 24/7, so they do need to be taken 7 days a week, unlike the stimulants, which are in and out of your system very quickly and only need to be taken on the days when you need them, for most kids, Monday through Friday. And so these, you take them 7 days a week, and they do take some time to really kick in, sometimes a number of weeks, or sometimes you have to go up on the dose a number of times. And the side effect profile is a little different too. They're more mild, so you're a lot less likely to have the stimulant type side effects like the sleep loss or the appetite loss, the heart rate or the blood pressure increases. But you can still get them, but they're less likely, more mild. But now, because of the hybrid nature of these meds, you also have to watch out for antidepressant type side effects. Stomach aches, headaches, dizziness. There's that 1 in a million chance, we call it the black box warning, that these meds can actually increase suicidal thoughts. In anybody under the age of 26, I will tell you that is highly unlikely, and other research has shown maybe that's not even a phenomenon. We don't know, but it doesn't matter. We watch for it. Psychiatrists, we ask about it. Okay, now you're on Strattera, any suicidal thoughts, etc. We're just careful about that as we go. There's another brand of non-stimulant medications. We call these alpha agonist meds. And these were meds that were created to be antihypertensive, to reduce blood pressure. Meds like guanfacine and clonidine, and they both come in immediate release and extended release formulations. And they work especially well on the hyperactive impulsive ADHD symptoms. And from what I've seen, even in the younger patients, grade school, maybe middle school kids, they tend to work very well. And they work at calming their body down, which by its own nature will help them to stay focused on what they're doing in school as well. A lot of times, maybe they don't work as well with the older kids. One of their main side effects that they produce is some sedation. And so sometimes the older kids will say, well, they just make me sleepy. They don't really help me focus very much. They can also enhance norepinephrine functioning. I left the diagram out on this one because it's just so complicated. It's actually hard for me to follow all the different changes that are going. So I don't expect to put that up here and have that be something that anybody understands. Needless to say, like the previous meds, they enhance norepinephrine functioning in the body. That's their main avenue of effect. And again, you watch for sedation and sleepiness, but since they were created to reduce blood pressure, you have to make sure that blood pressure doesn't get too low with these meds. And for some young kids, it can have a paradoxical effect. It can actually make them more hyper. That's, again, very rare, but we watch for that. And last but not least, there is, if none of these meds seem to be really doing it, or a kid's having a lot of side effects, sometimes we turn to a very light solution, looking at 2 antidepressant anti-anxiety meds, Wellbutrin and imipramine. So Wellbutrin, bupropion, is an antidepressant that's in a little bit of a different category. It's used as an antidepressant, anti-anxiety, but as opposed to the serotonin meds, it also has an effect on the dopamine and norepinephrine systems in the brain. So since those two neurotransmitters are implicated in ADHD, for some people it can really help with ADHD and improve those ADHD symptoms. Of note, it's also a nicotinic receptor blocker, which is why some people actually take Wellbutrin to quit smoking, believe it or not. And then imipramine is a member of an old school class of antidepressants called TCAs, tricyclic antidepressants. This is, again, still used here and there for depression, anxiety. It works via its effect on the serotonin and norepinephrine systems in the brain. So again, sometimes we turn to these two meds when all else fails, but they can be very effective. So again, this is just kind of a tip of the iceberg approach to looking at ADHD, ADHD diagnosis, ADHD treatment, some of the pitfalls and some of the nuances here that we really want to consider when we're thinking about treating somebody for ADHD. But again, there's a lot more detail to this. If you have questions, you can always contact me. I think, yeah, the link to my website is on this slide. You can let me know. Happy to entertain any questions from viewers now too. Thank you so much. I'm sorry, I couldn't think of a good way to say that without it being a huge pun, but thank you for your attention throughout the talk. Thanks a lot, I appreciate it. And thanks, Linda.
Oh, thank you, Dr. Young. That was really informative. I really
Thank you.
appreciated the chance to learn with everybody. We have a few minutes if people want to type in any questions in the chat. A reminder, there's some chat bubbles at the top of your screen to help open those up. And in the meantime, I have a couple questions here. Do you have any suggestions for or tips on engaging kids in their treatment plan? I recognize that could be an age-appropriate thing, but I'm just thinking, generally speaking, do you have any suggestions for parents to help their kids kind of take some ownership in that?
Yeah, for sure. And this definitely gets more difficult sort of the younger the kid is. But even with young kids, I found, and this comes down to, having a longer session and the ability to really listen to a kid, develop that rapport with a kid, talk with that kid. And a lot of times, even with the young kids, I discover that they're already, struggling with a lot of difficulties in school. They see that they're not keeping up with their friends in class. They see that they're sort of, quote unquote, getting in trouble a lot at school and at home. They don't like living that way. They feel very unsuccessful. They might have a real low self-esteem about this. Again, depression and anxiety symptoms might develop down the road as a result. So in some ways, if you kind of go through a little bit of almost like a motivational interviewing therapy with them and try to see what are their goals, what are they frustrated by, what do they want to work on, a lot of times you'll actually find that they have a lot of motivation to focus better, to get things done in a more efficient way. And especially when the kid gets older and into high school, they just know. I mean, they're spending 7 hours a night on homework. Their friends are spending 2 hours a night, and they're getting B's when they know they can get A's. They're very frustrated. They're very motivated. And sometimes actually that might backfire. And I will say, as a clinical pearl here, that there are some kids who come to me in high school. They might be struggling with anxiety or depression that needs treatment, but they're hanging on to those ADHD meds for dear life. They think if you go down 1 milligram on this medication, I'm going to fail out of school, I'm going to fail out of life. They're really, really cautious and really, really worried. So it can backfire almost. They might have too much motivation. And that has to come up in the therapy portion of the visit too, where you address that, you look at it and say, wow, it sounds like you're really worried about this. What's going on? And so, yeah, that could kind of go both ways. Great question, Linda.
Yeah, well, thank you. I've read a little bit about motivational interviewing, and I think that's gives some great tips on that. We have a couple questions in the chat. The next one, can you speak to the specific approach of CBT, the research supports to treat kids with ADHD, and generally at what developmental age are kids responsive to the CBT type of therapy?
Yeah, that's a great question. And the second part, it kind of depends. Some kids just in general, regardless of their age, are either more or they get either more or fewer benefits from the CBT. I mean, the CBT requires a certain, as they say in the literature world, suspension of disbelief, right? You have to go in and say, okay, I'm going to just try these exercises. I don't know what they're going to do for me. I might feel that they're kind of silly, but I have to kind of go through them anyway. And the therapist gets to know that kid, okay, what's appropriate for them, what isn't. And as the name suggests, there is a certain cognitive component, meaning let's look at your thoughts about your school performance or your ADHD in general. Let's look at your automatic negative thoughts that you have about yourself in an academic situation, in a situation where focus and calmness and planning is required. Let's look at the cognitive piece. Now the behavioral piece. What do you want to do differently? What are you going to try to do differently? As anxiety provoking as it might be, as hard as it might be, can you use a Pomodoro timer to try to keep yourself in that seat for 25 minutes and then give yourself a 5-minute break and then do it again? There are certain techniques here that I kind of go through, but mostly I'm sort of augmenting what the therapist is already working on with that kid in CBT. And it can be very effective. There is a lot of research out there. And a lot of times, if you're searching for a therapist, again, ADHD coaches can do a lot of this. But if you're looking for a specific therapist, you want to find somebody who's trained in and comfortable doing cognitive behavioral therapy. So hope that kind of answers part of the question there.
Yeah, absolutely. There's another one in the chat. The question is ADHD a dopamine deficient state? Is part of ADHD seeking out the things that stimulate the dopamine releases more than the individual without ADHD?
Yeah, that's a really good question. And again, unfortunately, it's a question that doesn't have a fantastic answer because it's really hard to look at the molecular biology of a living person's brain while they're doing certain behaviors or performing certain tasks. We have fMRI and PET scans and things like this that we use in research, but it's not as definitive sometimes as we'd like it to be. We can't watch individual, dopamine molecules. Where is it flowing? Where is it going? We try to take cerebrospinal fluid concentrations of dopamine, and those studies haven't been great. You would expect to see lower dopamine in kids with ADHD, and it doesn't quite look like that in all of the studies. So it's hard to say. But back to that slide that I showed you a while ago, yeah, there is the theory that the dopamine that's there isn't being used properly. It isn't being used efficiently. And that's where the medications come in. It helps the dopamine to go where it needs to go and to be used more appropriately. There is a lot of talk these days about what is dopamine, people seeking dopamine. A lot of people come to me using the phrase dopamine hits. I punched this kid in the face and it was a real dopamine hit. I mean, you really have to be careful with that. Yes, it's true that you see a lot of kids with ADHD being daredevils, doing, big jumps on their dirt bikes and skateboards, or, running out into traffic and things, but it's dangerous and you have to be careful with a lot of that. And so you have to be careful kind of where you go with that. Unfortunately, we haven't found a role for just meds that increase dopamine. A lot of times these are meds that are given for Parkinson's disorder, and those meds don't really seem to help ADHD a lot. So this ADHD deficient hypothesis, it doesn't quite go to the limits there, and it doesn't tell us everything. But yeah, there is something to that dopamine theory and why people with untreated ADHD are often thrill seekers, trying to do that a lot more maybe than kids who don't. And again, that's something that these medications should help with for the most part. So yeah, great question.
Yeah, we've had some really good questions. We are getting to the end of our hour, and I just want to extend another thank you, Dr. Young, for that, for your time to present and such an informative presentation at that. You definitely have put into perspective the importance of that partnership with a clinician in the process of therapy, along with some of the other supports you mentioned. I really enjoyed learning about the chicken and egg slides. Those also were, it really, again, it shows the complexity of a diagnosis and where to start. So I hope all
Great.
the people out there watching the video recognize that there's a wonderful community of supports, and just reach out if people need help along the way. So now we just want to extend our thanks to everybody who attended. The presentation will be shared with you via email in the next few days, and also posted on our website. Please share this information with your family and friends. We're so grateful to be a part of a community resource, and we encourage everybody to reach out if we can be of support. And I believe Dr. Young's information is on the slides as well. We are very grateful for our partnership with him too. So we wish everybody a wonderful day, and thanks again for joining.
Thank you. Thanks, Linda. Appreciate it. Thank you.
Thanks. Bye-bye.
Bye-bye.